Respiratory drugs, Chapter 37. So before we talk about the respiratory drugs, let's talk about all the different types of respiratory diseases. Just very briefly, chronic obstructive pulmonary disease, or COPD. You'll see a lot of that in the course of your nursing career. Then there's asthma. There's a couple different categories of asthma. There's intrinsic, where it happens for no reason. Extrinsic, where it happens because of an allergen. Exercise-induced, which is what I have. Drug-induced, so drugs can cause asthma, of course. And then there's something called status asthmaticus, and that's a prolonged asthma attack that doesn't respond to your typical inhalers. It can last hours, and if you're lucky enough to survive the hours that it lasts, that's wonderful, but most people don't. So it is an absolute medical emergency. So if the typical asthma treatments don't work, and it's considered status asthmaticus, and it is an emergency. Then there's chronic bronchitis, where the airways of the lungs become narrow, and it's chronic. Then there's bronchospasms, where the bronchioles narrow and spasm. Usually that's due to inflammation of the bronchial mucosa. So the alveoli still are exchanging gas, but the bronchioles that pass it through so that you can expire and bring it in so that you inspire the air to reach the alveoli is really narrow. It's like breathing through a straw, and it causes problems, causes difficulty breathing and wheezing and all kinds of stuff. And then if you add secretions to that, you're really in trouble. There's a disease called emphysema. Emphysema there's some destruction. It's a disease that destroys some of the alveolar walls. And so I won't go into what it's caused from, but just know when you don't have all of the alveoli you need for proper gas exchange, it's like the surface area is smaller. And so people will have to take more respirations to do the same amount of gas exchange than a normal person would. And their respiratory effort is tremendously impaired. They just really struggle because they don't have that surface area. They're getting the oxygen in, they're getting they're expiring and inspiring normally, but their surface area for gas exchange isn't there, so they struggle there. Okay. So asthma drug therapy. Look at all this stuff. This whole picture is to show you, look at all this stuff. Okay, you'll see beta-2 agonists. Remember how they impact the bronchioles? Then you'll see steroids to decrease inflammation. There's just so many medications for asthma. Most of them are inhaled because the inhaled, they're like topical meds for the lungs. And topical meds are most effective. Okay? Now, bronchodilators. These drugs relax the bronchial smooth muscle, which dilates the bronchi and the bronchioles that are narrowed as a result of the asthma. And there are three types of them. There's beta-adrenergic, there's anticholinergic, and then there's something called xanthine derivatives. And these drugs are used during an asthma attack. These are the inhalers those asthmatics whip out of their pocket. And if you see in movies, oh, I don't have my inhaler, and then they pass out or whatever happens, but people have to carry them around, and they are used to quickly reduce airway constriction and restore normal airflow. They're agonists or stimulators of the adrenergic receptors in the sympathetic nervous system. That's the beta-adrenergic anyway. Beta-adrenergic are the adrenergic agonists or stimulators. So sometimes these drugs have to be used with another drug to be effective. So there's all kinds of drugs. You can see the list: short-acting, long-acting. And just know that there's non-selective adrenergics, non-selective beta-adrenergics, and then selective beta-2 drugs. Non-selective stimulate the beta-1 cardiac and beta-2 respiratory receptors. So an example would be an EpiPen. And then non-selective beta-adrenergics stimulate both beta receptors, and an example would be metaproterenol. You don't need to know these names, just know non-selective adrenergic are alpha and beta. Then non-selective beta adrenergic are beta and beta. And then there's selective beta 2. Beta 2's the beta receptors, which would be like all of the bronchodilators, like albuterol. So the mechanism of action of the beta adrenergic agonists begin at the receptor site and then ends dilating the airways. So I don't know if you've heard of this, the cyclic adenosine monophosphate, CAMP. Activation of the beta-2 receptors activate CAMP. And it's lower C, capital AMP. And when this is activated, it relaxes smooth muscle in the airway and results in bronchodilation that increases airway. So it relieves the bronchospasms, and it's used for acute attacks. It's even used in hypotension and shock. It just helps somebody breathe. So you wouldn't give it if somebody has hypertension, if somebody has a dysrhythmia, if somebody has a high risk of stroke, because this drug vasoconstricts. And we don't want to vasoconstrict, right? So beta adrenergic does beta 2, but the adverse effects are really, really bad. They have tremors, they have chest pain sometimes, hyperglycemia, a real bad headache. Examples of beta adrenergic agonists are albuterol and salmeterol. Proventil and Ceravent are the name brands. You're going to see these a lot, and they are beta adrenergic agonists. They help people breathe. Anticholinergics. Anticholinergics bronchodilate because they block acetylcholine. So if you remember from the parasympathetic, acetylcholine causes bronchial constriction and narrowing of the airways. So anticholinergics block that. They just help dilate the bronchioles. It helps reduce secretion, and it prevents bronchospasms. Anticholinergics are used mostly for bronchitis, emphysema, not for the management of acute symptoms. Atrovent is the name brand of the oldest, most commonly used anticholinergic bronchodilator, and it's ipratropium. I-P-A-T-R-O-P-I-U-M. You can use it as an inhaler or a nebulizer. They're great. Then there's xanthine derivatives. The xanthine derivatives are plant alkaloids. They're things like caffeine, theophylline. Only theophylline is used as a bronchodilator. Xanthine drugs also break down CAMP, so they also relax smooth muscles and allow for bronchodilation, just like the anticholinergics do. Then there's lots of non-bronchodilating respiratory drugs. So these are three categories: leukotriene receptor antagonists, corticosteroids, and mast cell stabilizers. We're not going to spend a lot of time on anything other than the corticosteroids. So I'll just slip through the slides so that you can see the bullets of what's important here. So these are non-bronchodilators. It's just a new class of drugs. Singulair is very common. I think they still have, whenever there's TV ads for a drug, it's new. So these do work. Just a different kind of drug. Mechanism of action. Okay. Drug effects. Prevent contraction in the bronchial airways. Decrease secretion. Okay, steroids. So, a lot of folks with asthma are prescribed corticosteroids because corticosteroids decrease inflammation. When they decrease inflammation, they increase the responsiveness of the smooth muscle. So just that anti-inflammatory process really helps stabilize the membrane. They're used for bronchospasms. They're used for asthma, persistent asthma. If somebody has a random asthma attack, they're just going to carry around an inhaler. But if somebody's got really bad asthma, they're going to be on a corticosteroid. Some people with asthma or acute exacerbation of COPD they're even on IV steroids. So now let's talk about the inhaled corticosteroids. You wouldn't want to take it if you for the sole therapy for acute asthma attack. You have to take it with other things. Okay. You wouldn't take a steroid if you have a yeast infection, because you'll just make it get worse, or a fungal infection, you'll make it get worse. Did you know that steroids make fungal infections worse? So if you have a rash and you put a steroid on it, it's going to get worse and not better. That's how you'll know it's a fungal infection, like, what's the circular one that you get from the cats or the animals, ringworm? It'll get worse. So if you have, if you're on corticosteroids, you're more likely to have some drug interactions. So your glucose levels might increase. So if you are diabetic and you're put on a steroid, you might want to watch your blood sugars because your glucose will increase. Dilantin, rifampin. Rifampin is a TB drug that we'll talk about in another one of these videos today. These drugs interact with steroids. Cyclosporin interacts with steroids, so lots of drug interactions. That's what you need to remember from this. And then the other two types of asthma drugs that were on the original slide, not the original slide, but the slide before the LTRAs. There's just a couple more asthma drugs. So all of these things, the adrenergic blockers and the anticholinergics and the steroids are the most common. So the others I have on the slides just so that you know there's a lot of asthma drugs, all right? So be aware of what kind of drug you're giving and what it does. The most common are the three that I just mentioned. Nursing considerations, do your assessment. Do your basic respiratory assessment, skin color, skin turgor, cap refill, baseline vital signs, respirations, O2 sats. Patients need to do preventative things. So there are allergens that precipitate bronchospasms and asthma. They need to stay away from that. Some people with COPD have an attack because guess what? They smoke 3 packs a day. Or they're stressed, or they live in a city with lots of pollutants, or they're dehydrated. So all of these things precipitate respiratory issues. And that's the first preventative thing that you need to encourage your patients and teach them. Beta-adrenergic agonists, special considerations. Albuterol, if you use it too often, it loses its action. So it stops working. You have to switch them to something else. Patients need to take their medicine as prescribed. So many patients with lung disease take too much, and they shouldn't. Patients need to know for the beta-adrenergics that they're going to have maybe insomnia at first. They're going to be jittery, restless, have palpitations perhaps. The xanthines. So they should not take if they've had any kind of GI disorders. And a lot of the xanthines are time released, and so you need to know if you're giving them something that's time released. They should not crush or chew those kind of products. There are some foods that reduce levels of xanthines, so high protein, charcoal, broiled foods, some low carb foods decrease the levels And then you're going to love this. If they're smokers, which if you have asthma or COPD, you really shouldn't smoke. But if you're smokers, it enhances the metabolism. So if it's metabolized faster, there's less in your system, right? So it's not going to work very well. Let's see. And xanthines are used for chronic management, not acute. So COPD, chronic bronchitis, not acute asthma attacks, it will not work. Corticosteroids, you have a risk of developing fungal infections, especially in the mouth, and yeast infections in the mouth with steroids. So you want to make sure that you rinse your mouth after you do the inhaler. You want to make sure that you do good oral care. Patients need to be taught that. They need to be taught how to use their inhaler, period, for any of these kind of medications. And they need to know how to keep track of the number of doses in the inhaler device. We'd hate for them to run out of doses if they have an acute attack and they don't have any meds in their inhaler that they have with them. That's the reason they have to keep track. Okay, we're finished with this chapter. You'll have one more video on chapter 41, 42, and 43. Hopefully it'll be less than 20 minutes long. Thanks for listening.